Hello to everyone and welcome to our first ever Sarcoidosis of the Eye Patient Day. My name is Leo and I'm the Senior Executive here at Sarcoidosis UK. I really hope everyone who's joined us today as well. We are really excited about this event today. This is our first ever event about sarcoidosis of the eyes, and we have some really fantastic speakers joining us to talk about sarcoidosis affecting the eyes. Now, before I do hand us over to our speakers for their sessions, I wanted to start off today talking about patient experience, which is actually quite a difficult task when it comes to a condition like sarcoidosis, because something I learned very quickly back when I started with Sarcoidosis UK at the start of 2020. What I learned was that sarcoidosis affects every patient differently, and I'm not exaggerating when I say that no two patients are the same. So rather than me talking to you about this and trying to summarize the patient experience, I caught up with 6 sarcoidosis patients last week who very kindly agreed to share a bit of their experience with us, which I recorded and put into a video that I would like to share with you all now.
It's been a long time since it's affected me seriously because I'm treated systemically now, but in my teens, I would have swollen eyelids, red eyes, painful eyes, itchy, and it felt like they were gritty, and it didn't really affect my sight until I developed neurosarcoid. And then if I was to say I need a rest and I was waking up a bit too soon, then everything would be blurry. And I would have to just lie with my eyes shut until I got the rest I needed, and then they were okay.
I was watching television and a scratchy image appeared in my left eye. So the next day, it was still very, very sensitive to light. I phoned my local optician, saw them. The optician noticed that the pressures were very high and sent me to the local hospital, who then diagnosed sarcoidosis. My symptoms became worse with floaters, which were like kind of snakes and dots. The light sensitivity was really, really bad, and my eyes became very, very dry.
A sudden onset sicky headache, and I wasn't prone to migraines. And within 10 minutes of that, and feeling instantly unwell, my left eye absolutely streamed. And then the next day, the eye was pink. The next day again, the other eye was pink. And over the next 2 weeks, I began to lose my sight. My computer just receded. It got further and further away from me. And what was distinct black and white became a really faint grey. And then I couldn't see the captions on the TV news. And then I couldn't see items on supermarket shelves distinctly. I was blinded by light, and when I could normally see 5.5 fields distance, I could only see 1.5 fields.
First I knew was pain in the eyes, and I'd never had that before. So I went and looked in the mirror and saw that my eye was very bloodshot. So I didn't know what was causing that. I knew I had sarcoidosis, so I knew it was possibly related to that. So I got in touch with one of the eye doctors, and they saw me later that day and examined my eyes with a slit lamp, which was really uncomfortable because it's such a bright light they use to be able to look at the front and the middle and the back of your eye in great detail. So that was really horrible. And but it confirmed that I had a lot of extra cells in the front of my eye, and the eye itself was very inflamed, and we needed to increase my dose of steroids considerably, which we did, and add some drops, and things settled within a couple of days. Was a lot better, but it took some weeks before the changes in the eye settled. And then I had a really bad Saturday morning when I lost vision in my left eye. Couldn't see anything, like a huge great floater in my eye. I could be aware that there were bits at the edge, but I just looking through the focusing bit of my eye, I couldn't see anything. Couldn't see my hand waved in front of my face, couldn't see anything.
it's difficult to know whether what could be an everyday type of ache or chest infection, whether that's an exacerbation or a flare of the sarcoid, or if it's something completely independent of sarcoid. Unfortunately, due to using oral steroid and inhalers for asthma in the years prior to being diagnosed, I have secondary adrenal insufficiency and require a maintenance dose of steroids on a daily basis, which has to be increased if I've got any pain, trauma, taking antibiotics, infection, and even stress can reduce my steroid circulating in the body.
My biggest fear would be that it does permanent damage and I lose my sight permanently, definitely.
At the moment, the uveitis, which was caused by sarcoidosis, may return. At the moment, the right eye seems to be clear, the left eye is quiet. So there's probably still a tiny bit there, but that is my concern, that it will all flare up again.
I found the Facebook groups and links to yourself, the Sarcoidosis UK, absolutely invaluable. It was just so reassuring to speak to people who are going through exactly the same thing, had exactly the same fears and worries. It was absolutely amazing.
Sarcoidosis UK has got a lot of downloadable leaflets, and I have downloaded leaflets for my employer about the fatigue that I did mentioned a couple of minutes ago, because I have been off work this last couple of weeks. So the fatigue leaflet will be going in with my sick line, just to say that, yes, this is a real thing. I talk quite openly at work about my health conditions if somebody's willing to listen to me, because we do see sarcoid within the eye clinic. And I think it's important that my colleagues not only know what my limitations are, but know a bit about the patients that they may be looking after. And that if I'm having a difficult time, I can go in and say, no, it's a great today, just be careful, you know, sort of what I'm doing, etc. Don't put me in too busy an area. And I've just got to be as open as possible with them.
I turned to the Sarcoidosis UK Facebook group. That was my first port of call. Then I turned to the leaflets on the website. Then I've used the forms, and I'm still using those today. Then I contacted the nurse. Oh no, I went to the support group, you know, online. And lastly, I've used the nurse. But also I've used the RNIB, Royal National Institute for the Blind, because I wanted to prepare myself for worst case scenarios, and their support was invaluable to me.
I get a lot of support from my family and from very close friends, but I find your acquaintances find it all very difficult, because all they say is, but you look so well. And I just, because now the swelling's gone down, because I mean, I feel in a different position to people who have, I mean, I do have sarcoidosis in my lungs and other places, but the people who you can't see it, it must be immensely difficult. But once the swelling went down on my eyes, people were just, oh, you don't look like there's anything wrong with you. And that can be a little bit, well, I don't know what to say to that. So I tend to get support from people who understand, because honestly, I think I had a period of grieving when I first got the diagnosis, because I'd retired and I had this idea of what my retirement life would be like, and this is going to affect that, obviously. Well, it already has.
My main tip would be to start what I call a health timeline. I've gone right back to 2015 when I was first diagnosed, so that was where I managed to get, I'm terrible with remembering dates, so that reminds me of what date, what happened, the outcome and the future plan. So even the fact that I've got my COVID boosters, that's within my timeline. So, you know, I've got 3 different consultants that look after me, so I can cross-reference different clinics.
I suppose the big thing for me was that positive kind of, right, this isn't going to define who I am, I'm going to carry on regardless. And although that can be helpful, I actually think you can't do that. You have to accept this is a condition that will affect a lot of things, and has for me affected a lot of things. So it's about that acceptance. That doesn't mean you're going to have an absolutely rubbish life, and it means that you need to make small changes that make a difference.
A lot of us want and try to do as much as we can to be the best we've ever been at everything. And we can't be that to everyone. So pick your fights. I found in with my sarcoid, it's been chronic, obviously, and the more I ignored it, the iller I got. So I'd be buzzing about like a humming top at one point, thinking this is great. I love all this activity, but then sarcoid would flare. So I learned through the years that really I need a lot of rest.
The expertise in the rarer types of sarcoidosis is scattered around the country, so you have to be prepared to do a bit of travelling, but it's well worth it when you do, because the relief when you find someone who just listens and says, oh yes, I've heard that before, yeah, I know what to do with you, that is such a relief.
You absolutely must unapologetically advocate for yourself to your medical team, to work alongside them kindly, to inform and educate them, just because sarcoidosis probably hasn't been part of their experience. I would say that you'll need to adjust to a new sense of normality, and I struggled with that at times. But the thing that would reduce me to tears out of everything was that I had to revise my thinking to working within my limitations, because at times they're very real and it's hard to admit.
Now, before I hand us over to our first speaker, I just want to say a really huge thank you to Carolyn, Alistair, Vanessa, Chris, Pat and Jackie, who shared their experiences with us there. Hearing sarcoidosis patient experiences is so important, and hearing your stories will have meant a lot to many of the people watching today, so thank you very much. Some of you might have noticed that some of the speakers mentioned that they found support from Sarcoidosis UK services, such as our nurse helpline, our support groups, or our leaflets. If you do want to find out more about any of those things, please do get in touch with me on leo@sarcoidosisuk.org or on our website, which is sarcoidosisuk.org. At Sarcoidosis UK, almost everything that we do is funded by donations. We don't receive government funding, so we really do need your help to be able to put on events like today, to fund our support services like our support groups and our nurse helpline, and to fund our research. So if you are able to, please do consider making a donation to Sarcoidosis UK. Any donation, no matter how big or small, really does help, and we really do appreciate your support. Anyway, that is pretty much it from me for now, but it is a great honour to introduce our first speaker, Mark Westcott. Mark is a consultant at Moorfields Eye Hospital, specialising in uveitis, and at St Bart's Hospital and Royal London Hospital, where he specialises in glaucoma. He also has and continues to play a very active and important role in research, so it is really so fantastic to have him here with us today. Mark's session is going to be about anatomy of the eye and how does sarcoidosis of the eye manifest. Mark, thank you so much for being here, and over to you when you're ready.
Okay, thank you, Leo. I hope people can hear me. Is that correct?
Yes, we can hear you.
Good. I'm just going to share screen and get things going, I hope. It's a pleasure to talk to everyone today. My job is to talk about some eye anatomy, some terminology, and to give you some idea of how sarcoid can affect the eye. I don't have any commercial interest in any aspects of this talk. This is just a kind of commercial slide disclaimer. Sarcoid can affect structures around the eye. This is a picture of someone with enlarged lacrimal glands. It's not very common. You can get orbital problems, eye socket. They're actually pretty rare, and I'm going to really concentrate on inflammation within the eye, which we might call uveitis. I hope people can hear me. This is a basic slide of anatomy. We might remember this from school. We've sort of cut through an eyeball. We've got the optic nerve at the back. We've got the front of the eye. We've got the cornea, the clear window. There's a lens. There's the front chamber called the anterior chamber, vitreous, and we've got some blood vessels on the surface of the retina. Just going in a little bit more detail, this is a picture taken with a camera looking through the eye. So this is the sort of picture that we can get as ophthalmologists. We've got optic nerve, blood vessels on the surface of the retina. The macula is the central bit of retina where you get your fine detailed vision, and we'll be talking a bit about that in some detail later. Okay, I hope people can see this, but the concept of what we call the uvea is a vascular coating. It's actually the middle coating of the eye. We've got the outer part of the eye called the sclera that we can see as the white of our eye. And then we've got the retina, and in between that is a vascular coating called the uvea. And the back of the eye, we call that a choroid. It's a highly vascular structure. And as we move forward, we've got something called the ciliary body, which is actually a gland that supports the lens inside the eye. And then just in front of that, it's called the iris. The iris we can all see. It gives us the color of the eye. So if you have blue eyes, you're going to have a blue iris. If you've got a brown eye, you're going to have a brown iris. But this continuous structure called the uvea, which is choroid, ciliary body, and iris, that is the kind of source of inflammation within the eye. How do we classify eye inflammation? Well, we kind of work from front to back. So anterior means front. So this is front of eye inflammation. We might call this iritis. Inflammation primarily centered around the iris. Iridocyclitis means inflammation around the ciliary body. You might have heard eye doctors talk about these terms. We move a little bit further back into the middle of the eye. We've got what we call intermediate uveitis. Just put simply, this is inflammation within the jelly of the eye. About 2/3 of the eye is a living vitreous jelly. It goes from effectively the lens to the retina, and this might be we might call vitritis. It's called the vitreous jelly. And then back of the eye, we have various structures that back of eye inflammation can affect: the retina, the optic nerve, the choroid, and even the optic nerve and the retina. So we'll be talking about each of these in turn, okay? So just to give us an idea of who gets sarcoid uveitis, this is just one slide. This shows prevalence, the kind of countries that have the highest rates of sarcoid. It's quite interesting, they're mainly northern countries. The UK is a high prevalence country for sarcoid. Scandinavia is as well, Germany, and we've got northern North America. In terms of sarcoid uveitis, it's said to be about 5 cases per 100,000, slightly more common in females. And this is a slide showing the kind of age distribution. It's quite broad. Most of our patients might be within their 40s and 50s, but we certainly see younger patients and a fewer older patients. It's rare to see very elderly patients present with sarcoid. So most patients will be in middle age, and there's there's a kind of shoulder on the left-hand side, so some younger patients. But Black and Asian patients are at increased risk. Just one slide about the pathology. It can affect the lungs, the skin, multi-system disease. Many of you would know that as patients, but one of the key kind of lesions we see within the eye is what's called a granuloma. It's a clump of inflammatory cells that forms a lump, and they're a collection of multinucleate giant cells. These are sort of specialized white cells that leak out through vessels, and there's fibroblasts that cause fibrosis, and it forms literally a sort of lump or nodule. So these are some skin nodules. This is a biopsy of a nodule in the lung. And this is a picture of the back of the eye. And these white kind of lesions are actually inflammatory granulomas sitting underneath the retina. So what are the symptoms of uveitis? Not everyone will get all of these, but typically if it's front of eye inflammation, you'll get pain, redness of the eye. Photophobia means sensitivity to light. If you have front of eye inflammation or intermediate uveitis, you're likely to see floaters. And if you have significant inflammation, particularly in the back of the eye, you're going to get blurring of vision. So let's work through our classification. I said we split the eye into front of eye called anterior, middle of eye called intermediate, and the back of the eye called posterior. If we start with the front of the eye sign, so these are some of the things that sarcoid can do. This is a snapshot picture of the cornea, and we can see that these are sort of deposits on the back of the cornea. We call these keratic precipitates. So these are sort of clumps of inflammatory cells on the inside of the cornea. You can sometimes get the iris sticking down to the lens inside the eye. And you can see that the eye is red and injected. These are some further pictures. So this is a front of eye picture. This is the iris, and we can see these nodules. So that typically sarcoid causes these inflammatory granulomas, and we can get them in the front of the eye. So these are sitting within the iris, and they're inflamed, and these are abnormal blood vessels. Here's another picture showing these inflammatory nodules. So these are inflammatory nodules in the iris. When we try to grade inflammation in the front of the eye, we use a slit lamp. You will have seen these in eye clinics. Effectively a kind of binocular microscope that allows us to examine primarily the front part of the eye, and we grade how many cells we can see, inflammatory cells in the front chamber. So there's a grading system. Let's move on a little bit deeper into the eye. So we're now going to talk about intermediate uveitis, which is inflammation of the vitreous jelly, which is the sort of middle part of the eye. Sometimes we call this vitritis or pars planitis. This is a slide. So it's not very, but sort of, apologize, it's slightly blurred, but we've tried to take a picture of the jelly within the eye. We can see that there's kind of debris here. So these are inflammatory cells within the jelly of the eye. So typically, patients are going to notice this as floaters, little clumps of spots within the vision. This is a retinal picture, so looking through the vitreous jelly, and we can see these deposits of inflammatory cells sitting within the lower part of the jelly. We actually call these snowballs because they're white and they're round. They look like snowballs. And this is a more severe patient where they've all sort of collected together, and we might call this a snow bank. So this patient has a very large deposit of inflammatory cells in the bottom part of the vitreous gel. Now we're going to move to the back of the eye. So these are various structures that we'll just talk about that can be affected in posterior uveitis. Posterior effectively means back of eye inflammation. So typically the blood vessels of the retina can become inflamed. So this is a color picture looking through the vitreous. These are retinal blood vessels. These are the retinal veins. And we notice they've got these white lesions around the sides of the retinal veins. So these are clumps of inflammatory cells that have leaked out of the retinal circulation. We sometimes call this cuffing, a sort of or sheathing. These are cuffs of inflammatory vessels that collect around the retinal veins. Okay, it can affect the retinal arteries. The retinal arteries are a little bit thinner, has a slightly sort of brighter orange reflex. And why is this important? Well, they can sometimes block the blood vessel. So clearly, if you have a blockage of a retinal vessel, that's potentially going to be serious. Some of you, if you have eye inflammation, you may have had an angiogram. We effectively inject a fluorescent dye into the arm or back of the hand. It's a yellow dye, goes around the circulation. We take lots of photographs. So this is the dye following the blood vessels, and we can see that all these little yellow spots are areas where it's leaking out. We would call this vasculitis. This is a simple color picture, and we can see we've got these white kind of deposits that are lining the peripheral retinal vessels. So this shows us that the retinal circulation in the back of the eye is inflamed. Sometimes you can get exudate. So these are clumps of inflammatory cells that are leaking into the retina. So we've got a magnified view of a retina. These are some blood vessels it should look, you should get this nice uniform kind of orange color if it's normal, but this yellow deposits, this is not normal. These are deposits within the retina, which we call exudate. This is a very characteristic findings of sarcoid. So these are inflammation of the choroid. This is the vascular structure underneath the retina. And we can see these discrete kind of deposits there, kind of yellowish lesions. These are clumps of inflammatory cells that are lying just underneath the retina in the choroid. Very distinctive. And this is a very typical feature that we see in sarcoid. Okay, so we've looked at some aspects of back of eye inflammation. A very important one is what's called cystoid macular edema. The macula is the central bit of the retina that gives us our very sharp, detailed vision we use for reading, for perception of color, and that can become inflamed. So cystoid macular edema is inflammatory fluid at the macula. It is the commonest cause of visual loss in sarcoid patients. And it's something, as our sarcoid specialists, we spend a lot of time treating. If there's swelling in the macula for a prolonged period of time, it will start to impair central vision. And in fact, treating macular edema is a key marker of success for many of our treatments and for many of our trials in inflammatory eye disease. So it's a critical problem. Very complicated slide showing all the layers of the retina. I wouldn't expect you to really go through this in detail, but put simply, we've got a slice through a retina. We've got pigment at the back. We've got the photoreceptors just in front, and then we've got some various wiring cells and then nerve cells that go on the surface of the retina to the optic nerve. Okay, and the amazing thing is that we can actually image this with technology called OCT, ocular coherence tomography. So this is a scan through a normal retina showing us the layers of the retina. We've got this pigmented layer called the retinal pigment epithelium. We've got some the line of the photoreceptors. So these are all the little rods and cones all neatly arranged. And we like to see these layers in a very neat sort of linear structure. This dip is actually a sign of health. This is called the foveal dip, and it's what we see at the fovea. But you can see the layers are all neatly arranged. This is a healthy eye, not affected by sarcoid. So this shows you what the sort of imaging we can see when we get macular edema. So bottom slide shows a healthy comparison. We've got all the neat layers. And in this eye, we can see that there's an elevation and then these large black spaces. This is actually inflammatory fluid. Think of it like salty water that's bogging up the retina. And you can see that it's actually lifted up the layers of the retina. So this is called cystoid because it's cystic macular edema. Something that we don't want to see as eye doctors, obviously, or in patients. Sometimes we can use the dye test to show it. So again, I've touched on what's called fluorescent angiography. We've injected some dye into the circulation. This is a yellow dye. It shows up as white on our photographs, and it's leaking. It's pouring out fluid. We shouldn't see this kind of whitish deposit in the central retina. And this is our OCT scan to compare. So this is a patient with cystoid macular edema. Just to see, well, why do people get this complicated slide? But this shows us a little bit of our understanding. We don't fully understand this mechanism. Many patients with inflammatory eye disease can get macular edema. You don't just have to have sarcoid to get this. But we've got a nourishing layer called the choroid. We've got a pigment layer. And we believe that there's sort of the capillaries or the microcirculation becomes leaky, and it starts to pour out these molecules which are inflammatory mediators. They've all got quite complicated names, and they attract fluid. They are inflammatory mediators. And many of our drugs will be directly designed to kind of block some of these mediators. Okay, so this is a very complex pathway of inflammatory molecules that are causing this kind of leakage of the circulation. In sarcoid, we don't know the fundamental trigger. So this shows us a picture of someone who has a severe back of eye uveitis, and he's got, well, the patient's unfortunately got everything. We've got inflammation of the circulation, so we've got these deposits around the retinal vessels. We've got choroidal deposits, which are these deposits that live in the nourishing layer underneath the retina. The optic nerve is swollen, and the patient also has macular edema, so the patient has the full house. This shows us some pictures. Obviously, the optic nerve goes into the back of the eye, back into the retina, and it's quite possible for the optic nerve to become swollen. So this is an optic neuritis. We've got these deposits around the optic nerve, and it's caused some swelling of the optic nerve. And of course, there's an overlap with neurology, because the optic nerve obviously goes to the brain, transmits signals from the retina to the visual system. And of course, if we have inflammation there, that's going to directly affect vision. Just a few slides of how we might diagnose sarcoidosis. We rely on some the findings we can see in terms of the eye exam. These are a couple of blood tests that we can do. We can look at what's called the angiotensin converting enzyme, which is a marker for sarcoid, and it can be raised in sarcoidosis. The lymphocyte marker can be lowered in sarcoid, and there's also an inflammatory mediator called interleukin-2 receptor, and this can be high in sarcoidosis. So these are some blood tests that we might do. They're not unique to sarcoid, but they can give us a kind of diagnostic clue. Imaging, we often liaise with chest physicians, but we might perform a chest x-ray to look for signs of sarcoid in the chest. And you can do more specialized imaging. This is a CT scan that shows enlarged lymph nodes in the chest. If you want to do even more specialist tests, you can do a positron emission scan, where you inject a weekly radioactive tracer, whizzes around the circulation, and it gets absorbed by these granulomas that are typical for sarcoid. So this is something that chest physicians or general physicians might organize. Here's a patient who's had what's called a PET scan. So these are active sarcoid lesions in the chest and the liver that are showing up, and actually the extremities as well. So just to touch very briefly on how we might diagnose, I'm not going to spend very long on diagnosing ocular sarcoid, but we look at some of the signs that we can see from front to back. We've shown nodules in the iris, deposits on the cornea, lesions in the retinal circulation. We look at the eye signs, and then we would also either ourselves or with physicians look at the systemic investigations. And there are various criteria for putting this together to make a diagnosis of ocular sarcoidosis. Okay, that is probably all I would like to say at this point in time. And I thank you for your attention.
Thank you so much, Mark, for that really interesting talk. If you've got a few minutes, we've had some questions sent in advance. Would you mind me going through those with you?
For sure, yeah. Shall I read them out and sort of go through them with, or would you like to read them? Well, why don't you read them out, Leo? Yeah, get a bit more interactive.
Okay. So the first person has asked, why is it that sometimes people only have one eye affected by sarcoidosis?
I mean, that's a very interesting question, and it is absolutely true. The answer is we have no idea why one eye only is affected. I would say that if you look carefully in the unaffected eye, you may see very subtle signs. So it may be that it can be quite asymmetric, which means from the patient's perspective, one eye is mainly involved. But if you look in the other eye and you do some very fancy tests, or you look in the circulation, you may see subtle signs. So it may not be as extreme as one thinks, but we can certainly see some patients where just one eye is affected, and we do not know why that is the case, I'm afraid.
Thank you, Mark. And it's often the way with sarcoidosis, isn't there? Lots of unanswered questions, and thank you to the person who sent in that question. Somebody else has written in and asked, well, they said, I read that sarcoid clinics in the USA advise patients to have annual eye exams, even if they have no symptoms. How many times a year should NHS patients with sarcoid have their eyes tested if they have no symptoms?
Yes, I thought this was a very interesting question. I mean, I suppose the good news is that if you have sarcoid in the eye, the vast majority of patients are going to know about it. You're going to have some symptoms of a red eye, blurry vision, floaters. So it is possible to have sarcoid in the eye without realizing it, but it's actually pretty rare. Given the pressures on the NHS, I think it's probably not feasible to send everybody up to the eye doctor if they have no symptoms and they have no problems. So I don't think I don't think we have the data to say that everyone with sarcoid must get an ophthalmologist or an eye clinic review. One thing I would say is a lot of this technology opticians have. Opticians are very skilled at identifying problems. They can look at the front of the eye, they can look at the back of the eye. Many of them have these OCT scans and these fancy scans and photographs. So I think every patient, whether they have sarcoid or not, should certainly go once a year to their optician for a general health screen. And if there are problems that, as in terms of they have sarcoid problems, the odds are the optician is probably going to detect it and would be able to refer up. So I would actually recommend that everyone with sarcoid, even if it's not in the eye, sees their optician at least once a year, and that's the best way of probably identifying problems. And the second thing is to be on alert for symptoms, which I've really covered.
Thank you, Mark. No, that's really helpful. The next sort of couple of questions have been about sarcoid with other conditions as well. And I just want to say to everyone watching that obviously we don't have access to anyone's medical notes. We can't really give specific advice to anyone, so these will have to be quite general answers. But somebody said they've been referred to have their eyes checked for sarcoidosis, but they also have GCA, which can also affect the eyes.
Yeah, I mean, GCA is an extremely rare condition, giant cell arteritis. There isn't, as far as we know, a link between the two conditions. There are usually fairly specific diagnostic criteria and tests to separate the two. It is possible to have both. I don't think we can really go into the details without knowing the specifics. But I did get two other questions. One was about blepharitis and uveitis, and one was about ocular rosacea and ocular sarcoid. And I think I'll just touch on those specifically. Mm-hmm. But blepharitis is a very common condition where you get inflammation along the edge of the lid, can cause irritation, some mild red eye, dry eye symptoms, discomfort. Ocular rosacea is again in the spectrum of blepharitis, can be a little bit more severe. It's possible to have both, and in fact blepharitis is very common and ocular rosacea is actually quite common. An eye exam or an ophthalmologist should be able to tell the part or two, because all these features that I've shown you today in terms of back of eye problems or middle of eye problems or problems in the iris and nodules, you won't get with blepharitis and you won't get with ocular rosacea. So it should be fairly easy to differentiate between the two in the eye clinic. The patients themselves, if you have very mild sarcoid affecting the front of the eye and you happen to have blepharitis, it can sometimes be difficult to tell the symptoms apart. And conceivably, with blepharitis, you can get a bit of red eye, you can get a bit of dry eye and a bit of photosensitivity, and you might not be able to tell the two apart. But I would have thought with a good eye exam in an eye clinic, it should be fairly easy to tell these two conditions apart. Do you want to read the final question, Leo, as well?
Yeah, so the last question we had was to do with pain in the eyeballs. This person has described it as it being like a headache of the eye, and they want to know what is it that's causing the pain. Is that possible for us to answer?
Well, it's a couple of things. For one thing, that with eye inflammation, particularly front of eye inflammation, you can get high pressure in the eye because our sarcoid can cause glaucoma, and that can be very painful. So that's one thing. We don't have the specifics of this patient's condition. The second thing is, clearly, if you have inflammation in any part of the body, unfortunately, that's painful. It's one of the key aspects of inflammation anywhere, is that it kind of activates pain pathways, pain receptors. So we do know that it can be painful. Having said that, in general terms, front of eye inflammation, which is the anterior uveitis, where there's a lot of inflammation at the front of the eye, is usually much more painful than back of eye inflammation. Those fancy pictures I showed of deposits in the choroid or the retinal vasculitis, it's actually usually painless. If you get inflammation of the coat of the eye, which is actually very rare, that can be painful. If you get inflammation of the optic nerve, that can be painful as well. So it may well be that this patient has quite severe inflammation, but perhaps more in the front of the eye. But we know that sadly that is one of the features of severe inflammation. Pain tends to go with this, but only in some aspects of sarcoid. And a word of caution is that a lot of the more serious back of eye inflammation, for example, those pictures of the macular edema with the cystic fluid in the retina, is completely painless. So sometimes the more serious back of eye inflammation we see is actually painless, but is more likely to affect vision. But I hope that answers some of the questions.
It does, Mark. Thank you so much for those really helpful and really detailed answers, and thank you for a fantastic presentation as well.
I would say that Professor Pavese will be talking about some treatments later, so I've prepared the ground for him. So he'll be talking about, for example, macular edema. So everyone might be saying, well, how do we treat this? But hopefully my job is to prepare some of the basics and the anatomy, and he will cover how we actually treat it. So I hope that will be even more enlightening later on. And I thank you very much, Leah, for organising this.
Oh, it's been an absolute pleasure, and thank you so much for being here. We really do appreciate it, and I'm sure the 70 people watching as well found that really interesting. So thank you.
I certainly hope it. Thank you.
Thank you. Okay, so we are a little bit ahead of schedule, so I think we will take a quick break. I'll quickly just whiz through what the plan is for the rest of the event. So after a short break, we will be having our next session, which is going to be called Visual Impairment as a Result of Neurosarcoidosis, which will be given by Dr. Tarunya Aaron. Following that, we will be hearing from Dr. Taz Braithwaite, and she will be talking about impacts, symptoms, and the need for more research. And then our final session of the day will be from Dr. Carlos Pavesio, who will be talking about treatment. So I think we'll take a 5-minute break, and then we'll be back and we'll hear from Dr. Aaron. Thank you, everyone. We'll see you in 5 minutes.